if you do have any questions, do feel free to ask. But just to get us kicked off, I suppose we'll hand it over to Tom and Brett. And if you could just give a bit of an overview of what your experience has been over the last couple of months as COVID-19 has been rolling out.
Stock levels we've been able to acquire for PPE has been wholly inadequate to be able to support our homes. We've got COVID cases in 2 of our homes currently, one of which has been incredibly hard hit. So they've got about 20 cases currently out of the 37 residents that are there. We've lost 3 residents have sadly passed away. We've had another 3 that are in hospital and another 3 that are on palliative care at the moment. As well as that, we've had huge levels of staff sickness and staff isolation. We've got 1 member of staff that is on critical care currently in a coma at the moment from that care home. The biggest challenge there is, and certainly from when the COVID guidance came out, was the amount of people that wanted to go and self-isolate. So we've had more than 15% of our workforce are now off with either with COVID related sickness, whether that's self-isolation or choosing that they don't want to put themselves in the front line because they're scared. We're obviously trying to support as many of the staff we can through that, and obviously the government schemes such as furlough have meant that we're able to pay those that are at the highest risk categories. The problem we're finding is regarding PPE, because we're only seeming to be able to acquire 300 masks per care home per week. It's kind of the maximum that we're able to acquire at the moment. So where we're wanting to be able to sessionally use masks, we're not able to do that. We're only able to do that in the homes where we have got the cases of COVID. There's also issues in terms of where you do have high levels of staff sickness as a result of COVID, that you're unable to get agency workers. So agencies are not prepared to put their staff into the homes which have got the COVID, which are the ones that are the highest risk. Fortunately, though, on the positive side of things, the staff that are there, because of the lockdown in many respects, are willing to work. They're no longer giving the excuse that they want to go out with their friends on a weekend, because there's no going out and the weekends don't really exist anymore. We've got a very good cohort of staff that are able to and are picking up every shift. We've not actually at this point had to send in sort of our emergency teams to go into the homes to support as yet. We're obviously having to do a significantly increased amount of oversight in terms of RAG rating all of our care homes on a daily basis, looking no more than 2 or 3 days ahead in terms of staffing situations and stock levels on PPE, etc. Things like aprons are pretty much impossible to get hold of at the moment. We actually put in an order for 4,000 clear bin liners because we're that concerned that we need to be able to provide the correct equipment for our staff. Things like face visors are impossible to get hold of, so we're using goggles, and we're not able to use them on a session. We're only able to reuse them, so we're having to decontaminate them after use. Fortunately, government guidance has changed on them being single-use sessional items to you can decontaminate them after each session. But it's been certainly incredibly challenging in terms of staff morale. A lot of staff feel that they didn't sign up for working on the front line and putting their families at risk, whereas their argument is always that the NHS or primary care did sign up for that. So that's the challenge that we're having, and having to make them feel that they are part of the solution. I think there's a huge amount out there in terms of promoting the National Health Service and promoting what the hospitals are doing in terms of the support of this virus. However, from things like supermarkets don't acknowledge care workers in the same way as they do hospital workers, yet there's probably a higher proportion of care workers that are actually coming in direct contact with COVID than there are actually hospital workers. And I think that's a real problem for us. I think on the flip side, it's a real opportunity to showcase actually how social care and health are able to work together, because I think we're probably more integrated than we ever have been. And the hope is that we can learn plenty of lessons from this and actually use a lot of this to move forwards. But I think staff at the moment really need media to get behind them as much as they are the NHS. Otherwise, I think as we get further into this, we are going to see more and more problems. I mean, in the UK, we're looking at reaching our peak on this weekend, I think they're saying. We'd been forecasting the 14th of April for the last month and a half. So it's not. We've been building up to this pretty well. Obviously, when you hit the peak, it's when it plateaus. You're still getting the same amount of admissions and the same amount of deaths. So that's when you start seeing the real pressure on the services. So we're expecting the next 3 weeks in particular to be some of the toughest. And certainly we're finding that hospitals where they're looking to discharge their patients into the excess capacity within care homes are being slightly disingenuous in terms of some of their discharge policies. So we've had to have really strong managers and ensure that they're working very hard and closely with our executive team. So we're having people that are sending us because we're not able to go out into the hospital settings to assess patients before they come into our care. We're having to rely on the hospital admission, hospital best interest assessors to do the assessments for us. We are finding that some of them have lied in their assessments because they're obviously under quite a lot of pressure to get people out of their care, and we've had 2 or 3 complaints that we've now had to send back to hospitals because we've had the same patient with 2 completely different sets of care records, basically trying to get people out of the care of the hospital. An example being, we had someone that was in hospital with COVID, had stabbed his wife previously, and the assessment we had received was that he was not a safeguarding risk and had not any cause for concern to our staff, yet he'd been in prison for 18 months, been discharged from prison to hospital, and then hospital straight to our care. And that's just one of probably half a dozen examples I could give at the moment of hospitals being slightly disingenuous and effectively lying on paperwork to free up beds, which obviously the discharge teams within the hospitals are under huge amounts of pressure to do that. But it's very difficult for social care that's always looked upon as the sort of the inferior partner to the NHS. Those are some of the sort of the main challenges, and I think obviously once you start getting into the cycle, the hardest part is when you've got your first few cases in a care home. It's that 48-hour period of getting the staff on board and understanding what it is and not running scared. After that, it very much normalizes, and you know who are with you and who aren't. So that's probably one of the more positives. But yeah, it's definitely a very challenging time. I don't know if Brett wants to add anything.
I would say from a sort of executive point of view, the most important thing that we see is the morale of our staff. The work that Tom and his team are doing on an hourly basis to keep the managers, the senior management team, the carers all supported, because they read the newspapers, they read their social media groups, they listen to what's happening around the world, and their view is, why are we coming to work? Why aren't we furloughing like everyone else and isolating, staying at home? We're putting ourselves at risk on a daily and hourly basis, which we take this risk back to our families for what is not a highly paid job. So to make sure those staff come in every single day to do that job at the coalface, to do extra shifts, is one of the hardest things to actually keep that staff group motivated. And if they don't feel that they're supported by their manager, the senior management team, by the company, they won't come in. And
no, Tom, I think we spoke a couple of weeks ago and you were outside one of the first homes that got hit by COVID, and you were about to go in. And to Brett's point, that trying to manage that situation and trying to get staff motivated and encouraged to go on. I think you were saying that some of them were just in tears, working double shifts and not knowing if they were infected and separated from their families.
Yeah, no, absolutely. So, I think just to say, it's not actually just the those workers. It's also the senior exec team. I mean, my day this morning started at 4 a.m. having a phone call from one of my senior regional management team that was dealing with staff that were so upset that he had packed a month's worth of clothes to go and move into a care home, which I had to say, we don't need to do that just yet, and try and calm that situation down. But yeah, we're turning up at homes where they're tired. They've made the decision to isolate from their families, so they've asked their parents to look after their children for the next 12 weeks so that they can isolate themselves and they can provide care within our facilities, which is so admirable, and I'm so proud of them all. And yeah, what we're doing is trying to motivate them. So we're going there on a sort of daily basis, trying to take them donuts, chocolates, whatever we possibly can do to try and keep them motivated. And one of the sort of the key challenges is to try and get across to them that we're not sitting in our ivory towers, that we're not self-isolating while putting them at risk and on the front line. We are there with them, but we need to be able to be free enough to look at the strategy of the business and deploy the right resource to the right areas at the right time. And that is so difficult when people and staff are wanting to wear PPE all the time and want to wear masks all the time. And we're saying, if there is an outbreak in your home, which you haven't got at the moment, there will not be enough PPE for you to be able to be safe. We are keeping you safe by making sure that we're putting the resource in the right areas. And that's the challenge, because we also have family members that are calling up and they are asking us, why are we not using PPE all the time? And we're saying, well, we're following the government guidance. We're trying to provide enhanced level of care. So we are going above and beyond the guidance, albeit not by huge amounts. But what we have to do is manage our stock. We don't want to create mass panic by saying we don't have the PPE to provide you, and you're right, this is the guidance. What we're having to say is that this is the managed approach. This is the approach that we're doing, and we're writing to local authorities that we work within and asking them to clarify their interpretation of the guidance, because some of the guidance is grey and it's open for interpretation. And whilst the local authorities are being very good at answering the telephone, they're also being very political in their answers. And some of their answers that we get are things like, one interpretation of the guidance could be this. And you're like, seriously, guys, this is I don't want to know what one interpretation of the guidance could be. I want to know what your interpretation of the guidance is, because you're the ones that will come in and criticise us if we don't do what you think we should be doing. And I think I had someone last night sent me an email and they said, with the limited supply of face masks, we acknowledge providers may not be in a position to follow the guidance to the letter and are practicing infection control as best they can. So, I mean, even the local authorities completely are admitting that there is complete lack of supply of PPE equipment.
There's a real growing concern here as well at the moment. They're trying to triage by need where that PPE is allocated. But one of the questions I just wanted to ask you, Tom and Brett, was what was your ground zero case and how quickly did it spread through the home?
So we believe we know our ground zero case. So we've got two homes with two ground zeros effectively. One was a admission from hospital where the patient had been in a ward with other COVID patients. When they'd come out of hospital, we'd isolated them in their bedrooms, but as per the guidance, we weren't using enhanced PPE. The guidance was and is that if someone comes to you and they've not got any symptoms, that you just treat them as normal. We were isolating anyway, but not using the enhanced PPE, which we are now have now introduced. And eight days after admission, they started showing signs. So that was one. And then the other one, we believe, was a member of staff that had been on holiday in Spain and returned from Spain. And again, guidance at the time was that if you come in if you haven't been in, if you're not showing any symptoms, then you carry on as normal until you show the first signs and symptoms of COVID. Now we're temperature checking every staff member that comes into the home. We're temperature checking our residents 2 or 3 times a day, and we're doing far more in terms of monitoring what and who could potentially be carriers.
The hospital mission was an interesting one, wasn't it? Because our agreement with the hospital over discharges to us were people that showed no symptoms had to go through a process in the hospital before they got discharged to make sure they had no temperature and they were in a certain scoring range, therefore they had no symptoms, or they'd had the virus and had to be 14 days past and no symptoms. So we've had a person who's been discharged to us from the hospital that showed no symptoms, had no temperature, passed all their checks, came to us. We isolated for 7 days, as we were asked to do. On the 8th day, showed the symptoms. So it's showing that even the hospitals can be discharging people that they're saying are fine, but in fact, because they've not been tested, they aren't fine. And that's our biggest problem at the moment. The testing in the hospitals, they aren't testing people they're discharging to the aged care sector. And our worry is that the next 2 to 3 weeks, as the NHS starts to have the massive wave come through, that they'll be insisting that we take COVID patients who are coming in on palliative care, so that as they free their beds up for those who come through that they determine they should work for to keep alive, they'll be looking to discharge the aged care sector, those that they'll be sending to us to die. And that's one of our concerns, that we don't have the PPE for that type of situation.
And are you getting any, when you've got an outbreak in the facility, or if you were required to take anyone with a COVID-19 diagnosis, do you get any extra support from the NHS or the local government in terms of resources or checking in?
No. So we're only able to access the PPE through the national supply chain anyway at the moment, which, like I say, is 300 masks per care home per week. We are aware, and they do have additional supply where you have got cases that you can access emergency stock, but we're not getting any additional assistance. In the case of the first care home, we didn't have a doctor visit for nearly 10 days into the home, as basically everyone refused to come in. We didn't have any of the residents tested for at least 10 days, the first 10 days of it, which is, we found staggering considering the risk levels that were in the care home. And yeah, we really feel that there's been a lack of support for our sector. There's a lot of local government quality teams that are making phone calls to say, oh, what a great job you're doing, and try and do a morale thing, but they're not actually offering any support.
Yeah.
Tom and Brett, it's Sean. Is it okay if I just jump in with a question?
Please, Sean.
Yeah. Just a couple of things, just from the context. So prior to this first initial infection outbreak, can you just set the scene for what level of infection control above and beyond business as usual you had in place?
So before the outbreak, we were doing, obviously very much focused on the hand hygiene perspective. But in terms of what we do in care homes anyway, we already operate at enhanced levels of cleanliness. We'd already locked down our care home, so we were having no visitors in before the outbreak. So there's no visitors coming into the care home apart from the healthcare professionals. So there's no entertainers coming in, there was no family members coming in. But in terms of enhanced PPE, we weren't using enhanced PPE because the government guidance was, and at the time, not to. And to be honest, we wouldn't have been able to anyway because there was no access to it. And really, I mean, where it comes to aprons and gloves, that's normal PPE for our sector. So the only real change, even with the COVID situation, is goggles and masks, which we already have on site for cases of flu or anything like that, but not to the extent where you've got so many cases.
Thanks for that. And I guess the other question I've got is, it's very concerning with the transfers from hospitals to your facilities. Has there been any direction from the authorities with respect to you wanting to transfer residents out of the facility into an acute care setting? Is that an issue that you're not able to transfer, that you're expected to be able to manage in that setting?
Absolutely. So one of the first things that happened when the COVID outbreak started is that district nurses told all of our unskilled, untrained workforce that they were no longer going to do the insulin, they're no longer going to do the dressings of patients, that they were all going to have to be done by the care home themselves. So obviously we've had to upskill rapidly our staff in terms of the dressings and the admissions of insulin. So that's one of the first things that happened in terms of us getting our residents from into the acute settings. We've still been able to do that in certain cases, but in other cases we do feel like the implication is that they're better off to die in the care home than they are to go into the acute settings. And I've been dealing with 2 or 3 actually today where the doctors have been saying they're not going to admit hospital. In fact, they're not even going to come out to see the resident because they don't feel that they would receive the right care in the hospital at the moment, and actually it'd be better managed within the care home. But these are cases which would normally be almost certainly dealt with in a hospital, where they're advanced UTIs with increased confusion. We've had incidents where there's been falls, which we would normally expect to see being taken into hospital to be have additional checks, where paramedics have come out and have said that they wouldn't be suitable for admission based on the parameters that they're working within now. So we are seeing that is the case, but we are also conversely seeing occasionally we are seeing someone admitted to hospital, so it's not stopped completely.
What's the response been from families in I suppose in the general sense, but particularly in cases where you've got significant incidences and where you are caring for people that are palliative?
So we've taken some different approaches. So where we've got someone that is dying, we have still allowed the family to come in and say goodbye under strict hygiene guidance. The only times we've not been able to do that is where that resident's family is also in a shielding category, and we've just said it's too high risk for them as well. But families in general have been pretty good. I'd probably say it's 80% very positive and 20% very, very beyond scared, trying to apportion blame on everything and extreme worry. So why aren't we wearing masks all the time? Why isn't mum staying in her bedroom? All of these sort of questions where we're answering and saying, well, we're following the government guidance. Mum doesn't want to stay in her bedroom. She still wants to socialise. She still wants to go and sit in the garden. That's her choice, not yours. And however much we want to safeguard people, we've also got to respect their wishes. And your mum has got full capacity. But, so yeah, it's challenging.
Has there been any families that have tried to discharge mum or dad from the homes?
No, so that's been a strange one. That's one we were expecting to see, but we haven't seen. I think I've seen one case of that, which was a respite resident that was only going to be a short-term, potentially permanent resident that the family decided to look after them. But we haven't experienced people removing them from the homes. The one thing I would say we have experienced is we're not getting private admissions at the moment. So we're getting no new admissions from the private sector. They are almost certainly staying at home or being cared for by family that haven't got anything else to do anyway. So
but also with the press. When care homes get in the media in the local area to show there's an outbreak and there's a number of residents dying, families then worry about, is the care home as bad as the hospital in terms of placing mum or dad? Yeah. And if we place mum and dad there, is mum and dad going to get it? And that's the worry we have as the sector at the moment is we've sort of managed the outbreak okay. What we're worrying about is the outbreak being imported into us by the hospitals. Yeah. Because we're not being tested, because they're under pressure to unload people out of their beds. We're in a perfect place if someone comes in to transmit the virus through our vulnerable age group, our vulnerable disability group. And that's the concern as operators we have at the moment across the country, is the NHS might get a control of it, but the next outbreak could be in the aged care sector as it's exported into us.
Yeah,
So it's how
look,
we manage that is our big issue.
It's really interesting to hear what you're saying. Thanks for giving us your time. It's quite scarily kind of familiar to the same issues that we're facing. You're probably a little bit further ahead, and we've just started to engage, I suppose, with the hospitals, starting to talk about not being able to transfer people. So it's really interesting to hear that. But everything else you've said about PPE and all of those things are the same sorts of things that we're experiencing here. But I was really interested in your comment about the first 48 hours is critical. From your experience, what were the key things that you needed to do in the 48 hours that you did, or things that you look back in hindsight and think I should have done that in the first 48 hours?
So I think if I start with the hindsight, so in hindsight, I'd have probably liked to have spent some more time with staff when there wasn't the outbreak, talking through exactly what would happen in terms of an outbreak, and making it very much more clear that there was likely or almost certainly going to be a case within the home at some point. We put out various bits of communication which have very much inferred that to them anyway. We've said the likely is we're going to be caring for someone with COVID, but I think when the reality hits quite suddenly, that's the bit that really scares people. And it's also those staff members that have got families at home, they're of a more vulnerable category, if not, and to try and go through that scenario and try and normalise that before it became normal. So the first 48 hours, we know the staff that will say, I can't work in this situation, I don't want to work, I don't want to put my family at risk, I'm not earning enough money here to do it. Care jobs are 2 a penny, I can go and get one round the corner. My husband works, I don't need to work. All of these things that come out. But if we could have got rid of those or alleviated even 2 or 3 of them earlier on, that would have helped us and will help us in the future. And that's something we're working on at the moment. But it's how you tell staff that you will be having a case of COVID is so difficult, because we're obviously still accepting admissions from hospitals. And that kind of differs with some of the staff's perspective over whether or not we should be taking admissions from hospitals, because they will obviously say, no, we should be locking down completely, take no admissions, barricade the doors, and we'll all be safe. But we're saying, well, actually, that's not necessarily true, because you're still going to the supermarket, you're still going out shopping, there's still chance of bringing it in. At least by us taking these contracted beds and we're bringing in people from the hospital, we're bringing in additional revenue so that every single bit of our resource can be focused on providing you the right equipment. It's just a case of supply. And so they understand that, trying to make sure that they understand the reasons why we're doing things as a business. And it's not just about us making more money, it's about safeguarding their jobs, but also safeguarding the finances and shoring up the company in such a way that we can buy additional PPE, we can continue to try and do the nice things. And so we're not worrying as a company. We're in a very fortunate position that we're a very strong company in terms of our finances are very stable. Our banks have been incredibly good, even though we've not asked them to. They've allowed us to have capital repayment holidays on all of our loans, which will give us an extra more than £1 million over the next year in terms of cash funds. We very much focused on making sure that our cash flow is in a position that the decisions we've made can support the staff better. But yeah, that 48 hours is absolutely critical in terms of ensuring the right senior staff are providing the right level of motivation to the workers. So I mean, we've been phoning our homes every day throughout this outbreak, which is something we've never done before. And we've just from a senior level, so director level phones every day. But when there's an outbreak, so this morning I was on the phone at 5 o'clock to one of the homes, speaking to night staff, telling them what a fantastic job they're doing and how valued they are. And I think that that's certainly one of the most important things in that first 48-hour period, is the right people from the business of actually making the calls. And it's not the person that they necessarily know, but it's someone that is so senior to them that they feel, wow, I'm a person, and actually being able to relate to them and know them by name and be able to say what a fantastic job they're doing is so important in that motivational piece.
Tom, in your analysis of your cash flow and the holiday that the banks have given you, obviously you're doing some forecasting. Do you have a sense of the financial implications on COVID on your normal operations in terms of increased costs, declining performance?
So I would say that it's too early to tell is probably the ultimate thing. We're obviously seeing massive increase in the amount of costs in terms of the PPE procurement. I think that the most worrying thing for us is what happens after as we come out of this, in terms of how the population reacts and where the council's budgets are, how we're going to what's going to be left over at the end. Certainly we're seeing some of our homes, well, this one home in particular, being pretty much decimated at the moment in terms of occupancy will be halved, and that's conservative estimate. But in terms of at the moment, with the additional beds that have been procured on block contracts with the councils, it's quite strong from a cash perspective. If I'm looking over the next sort of 3 months, is what happens after that when those contracts stop, when etc. That's probably a slightly more unknown. I don't know if Brett has a different view.
As Tom said, we've actually always been in a strong position. Steve, Clive and I, who started the business in '94, have been through a number of recessions and global financial crisis. So we've always been cashed up as a company because we've always been concerned. Our competitors aren't. And we're hearing on a daily basis of people they might have 3 or 4 homes and they've used Coles or Woolies as their supplier for food. Well, Coles and Woolies are no longer delivering to these homes. So the executives are out running around trying to find food for their homes. They're having problems sourcing PPE. They're on the margins anyway, so their occupancy is being hit in terms of referrals. Some organisations are talking about they might not make it past this pay round of April because the cost base of wages has gone up this year with the minimum wage going up 6%. But the government hasn't reflected that. But like Australia, they have not reflected that in the fee income. So the industry was already tight going into April without COVID-19. COVID-19 is going to knock people out of business. And that we'll start to see that happening in the next couple of months and quite rapidly unless the government steps in and helps out. So the problem is they're always a bit slow at helping. So we have to get that momentum going.
Yeah, just to add to that, I speak to a number of providers, and the ones that some of the providers didn't take block contracts with the hospitals because they wanted to shut up shop effectively. They've seen just even through natural attrition, their occupancy rates going down. They're not able to take private residents aren't coming in, and because they've not taken these block contracts, they're not getting like a normal social care referral because they're all using the block contracts. So they're now phoning me up and asking, should I take them? How do I safeguard my business if I do take them? And one of the concerns to them is that because they're now coming into it late in the game, they're effectively more likely and are going to be taking the higher risk residents coming in, or they may have their hands forced in a month's time, if it's still really bad, to take on COVID wards effectively. So where they've got capacity, they will need to look at taking in COVID positive patients, and just to maintain their cash flow. And as Brett said quite rightly, April was where we just had a 6% increase in all of our wages, our wage costs. And those homes that are purely on a socially funded background have only seen a couple of % increase in terms of their fee income. So they're already on a net negative in terms of their cash flow. Add in the PPE, and we're lucky at the moment. We're procuring our PPE through national distributors and able to utilise me selling my soul to say I'll have a meeting with them about potentially changing suppliers and various other things. But I'm seeing people buying face masks at £2.60 per mask when I'm paying 29 pence per mask. And that's the only way they're able to procure, is to be paying 10 times above the price that they should be paying on a mask. I mean, we were paying 8 pence on a mask a year ago. And like I say, a lot of providers now are having to pay sort of up to more than £1 a mask for something that some member of staff is going to use for maybe an hour. And that's something that's absolutely not sustainable on any level. So there are huge concerns through a lot of providers around doing that and making it sustainable. And I know that there's a lot of companies that are really concerned their cash is going to run out in 2 to 3 months. I think that there is a minority that will be over the next month, but I think certainly if this is a prolonged period of more than another month, we will start seeing some serious casualties in the sector, or else start seeing some much more serious cases of coronavirus taking over care homes, which we're already seeing in the news already.
Yeah. You guys are 1 week off peak infection, and we're probably a couple of weeks behind that. In your ramp up and given the lag that we have, what should we be using this time to do? What should we be encouraging government to do? And what should we be encouraging the sector to do in preparation for what you're going through and what you're about to go through?
I think the PPE thing is critical. If staff still feel safe, then they're more likely to come to work. I think that financially, I think that governments need to do far more to shore up the cash flow of businesses. And I think that there's things that they could be doing or looking at in terms of enhanced payments. I think that staff awareness of what it's going to look like in 3 weeks is critical. Yeah, that's really where I would be, and is government shoring up finances, ensuring PPE supplies, providers ensuring they've got the PPE supplies, and I think is absolutely critical, because if we had more, we would certainly feel a lot safer. And then staff making sure that their awareness is what it should be around.
With the staff, Tom's right. It's managing that message, because as you know, in the media, every day there's different messages from different countries about whether you should be wearing PPE when you walk around in the streets, whether you should be wearing PPE going to the shops. All that feeds back to our staff, who say, well, I read that in Austria they're making them wear PPE to go into the shops. Well, why aren't we working it at work? Why aren't we wearing it? We can't say to them, we don't have it, because that sends fear amongst the staff. We have to say we're following guidelines that says these are the times we wear it, other times we don't wear it. Because if they wore it all the time, we would run out. It'd be gone. And then we can't do our job, and then we will have a major problem in the industry that the virus will go through all the homes. So controlling that message with the staff, as Tom said, is vitally important. And if we had our time to go back, we would have prepared our staff a lot more for the eventuality of what's coming than being caught slightly on the hop. We weren't expecting it.
The one other thing I would add, really, from a government perspective, is that they need to make sure that social care feels as valued as primary care. And I think that that's certainly been a big problem for us in the UK, is that they don't necessarily feel that same level of value. There is bits coming through now, and it's almost like an after breath. But certainly the press questions are now starting to go round into social care, because there have been some of these major outbreaks within care homes.
Yeah,
I think the problem also, because they don't do testing, we don't really know the full extent of the outbreaks in the aged care sector, because there isn't wholesale testing of the aged care sector. So the sector doesn't really know how bad it all is, because we don't know out of our 20 residents in our home whether all 20 had COVID-19. We've had one person tested.
Brett, with the home that went from from resident 0 to 20, how long did it take to go to the 20 residents?
3 days.
How long?
3 days.
What?
Yeah. What we think happened was the staff member who had it, who wasn't having to isolate because she didn't have symptoms, it was one of the main communal areas that it seemed to go through all the people in that one. The one who's got the 2 cases currently, it's the person who's coming from the hospital and their next door neighbour in the home.
Yeah. So the staff member was a night staff member, and obviously the night staff tend to go into everyone's rooms when they're checking on them. So that was the devastation. So yeah, it's 3 days to get, I'd say something like 12 or 13 of them, and then it was just it's been 1 or 2 a day kind of thing after that, but clearly from the same source.
Kate just also has a question. She said, have you had any capacity to bring in additional staff to compensate for the lack of visitors and volunteers? And how has the lockdown impacted residents? Is there any way of preparing the residents and their families?
So obviously, in terms of how we kept we haven't been able to get extra staff in. So I say we haven't been able to. We've been able to recruit actually reasonably effectively. So there's been various different changes that we've had in terms of our ability to get DBSs. So there's now a free service to get our staff checked for their suitability to work, which is expedited. So we've been able to do that quite effectively, and actually we've done quite well at recruitment over the last few weeks. That said, where you've got an outbreak, you can't get staff. You can't get additional staff in, you can't get agency workers to work there, and it's incredibly difficult in those situations, and you're really relying on the home to be as resilient as possible, because as soon as you start sharing staff, you're going to cause huge amounts of problems. So in terms of families, we've obviously procured various technologies from the Facebook, iPad type things. We're doing a lot more in terms of FaceTime. We've had to buy various additional mobile phones so that families can phone onto a mobile phone, because the lines get incredibly busy, as you can imagine, with multiple people. But then we're making sure we're bagging our mobile phones up before we're passing them between residents from an infection control perspective. So we've tried to introduce technology far quicker into our homes to compensate that lack of contact. That said, we've also recruited certain family members that are the ones that come in every day, the ones that are very much are very sort of active anyway, and we've employed them as volunteers. So we put them through the DBS check, and we put them into through a volunteer program, which basically has said to them, you're not coming in here just to sit next to mum and give her a cuddle and a kiss in front of everyone else. It's, if you're coming in as a volunteer, you're going to do a 4-hour shift. Of course you can spend time with mum, but we're needing you to support the greater population of our residents. And we've seen that really positively in some of our homes. So quite a few of our homes have got family volunteers now. Again, they don't have anything to do at home, and actually it's an opportunity an excuse to get out, and an excuse to help. So that's been really positive for us, and really helped us as well in terms of our relationships with those more difficult relatives, because we can actually say to them, if you want to still come in, you can, but you can only do that as part of a volunteer thing, and we will train you on infection prevention. We will give you the tools to be able to support us, and you will actually be helping the whole home. So it's a much easier way of saying, no, you can't visit.
I think also what we've found is not everyone in terms of families are that well in terms of their technology. So if mum's 95, you could be the daughter at 70 and you're not great with Skype or FaceTime. So what our marketing manager has done is boost up things like newsletters, which we're now sending out to people in the post as well. So if they can't access Twitter feed and Facebook, They don't have Skype. We're sending out newsletters for each individual home of all the things and all the activities that are going on, lots of photographs. So at least the family are getting that communication that way as well. Because you can't rely on everyone being able to do Zoom or Skype, because not everyone can do that. And they may be self-isolating themselves, so their grandchildren can't pop in and see Granny to fix the Skype for her to speak to great-grandma. So it's looking at those other ways of being able to communicate. And as Tom said, your main phone lines are inundated on a daily basis by families phoning up, grandkids phoning up. So you need to make sure those lines are free as possible by having other forms of communication, like some mobiles as well.
Yeah, great. Do the residents seem scared, or are they fazed by what's happening in their home?
A couple, but to be honest, they're more resilient than the staff.
They're the war generation.
Yeah.
We've been through the Blitz.
So when the government guidance came out around shielding, we sat down with every single resident individually and said, obviously this is the shielding guidance, which is suggesting that you may wish to stay in your bedrooms and socially distance, etc. And pretty much 85-90% of them have said, bugger off, we want to still go down into the lounge, we still want to see our friends downstairs, and we can't stop that. We can advise them what the guidance is, but they've been far more resilient, and their views have been very much capsulated within the sort of, if I'm going to die, I want to die happy, not lonely in a bedroom on my own. I'm 90 something years old. I'm going to enjoy the last year of my life. I'm not going to spend 6 months of it sitting in a bedroom, and you can't really blame them.
Yeah.
And on the flip side, that can help motivate the staff as well, because you've got a resident group of saying, this doesn't scare us, we've been through the wars, dear, we'll survive this. So our resident group have actually been very positive, and they've also been very positive in supporting their family members. So we're doing lots of things with placards, which they hold up. We take photographs of, be careful, be safe, look after yourself, I'll see you soon, which we then send to the families of mum and dad having written messages to their grandkids and kids. We're also trying to find alternative ways of keeping our residents entertained. So a lot of our entertainers have now moved online. So they'll do a pottery class with our disabled residents in one of our homes via Skype. They'll do exercise via YouTube, those sort of things. So it's finding a more creative way to keep everyone engaged and everyone busy as well. And the entertainers all want to help because they're currently in lockdown as well, so they can't come in.
On a positive side,
yeah, we are very creative suddenly, aren't we?
On a positive side, most of our home managers have said how nice it is that the homes are so quiet in a lot of ways, because they haven't got district nurses coming in, they haven't got family members coming in, and they're all managing to keep completely up to date with their paperwork. So they've been quite pragmatic about it in a lot of ways. But
yeah.
So, just another question on the hospital transfers. You mentioned earlier when we were talking about declining occupancy for some facilities that it could well be that they would be then, I think you were saying, contracted by the acute sector to provide COVID-19, I guess, residency for patients beyond aged care residents. Is that formal government policy? Is that part of the plan that's been communicated to the health sector?
It hasn't been formally communicated, but it's a step-by-step approach.
Well, so basically what they've done, there has been guidance from the government, which is through the Care Quality Commission, that has enabled us to amend our registration very easily and very quickly, which is something that we wouldn't normally be able to do, which would enable us to change our registration from being that of residential to being COVID-19 and nursing. And we could do that in the space of hours, which would normally take weeks to be able to do. So there is already guidance and policy available to make that happen. In terms of dealing with COVID-19, we are getting daily phone calls in most of our homes asking, would we take a COVID-19 positive case? So that's already happening. And I'm sure that there are providers out there that have got an empty wing in the homes, or just cash flow issues that are basically taking people in now anyway, because they've got no choice. They need the money. They can't pay their staff if they're not at a certain occupancy.
So those calls that they're getting, that's from the hospital to say, would you take a COVID case? So then how would you manage that with your, say, for example, you're running a service, you have no active infection. What's the likely response from your staff and residents and their families if you within a day say, well, we're now going to provide this service? I mean, has that been thought through?
There'll be uproar. There would be uproar, but it comes down to communication, as you said. It's down to that, and that's why we've been very clear with all of the contracts that we've had that they're to come in as non-COVID cases. We can't guarantee that that's the case anyway, because as we know that there's not enough testing in the UK. That we know that if we're having someone admitted from hospital and we're being told they've not got COVID, then there's probably still a 30 or 40% chance they have. So we're having to treat everyone that comes in as a COVID case anyway. For us as a provider, where our homes aren't big enough, or we haven't got enough capacity in a set wing to be able to isolate people, we feel that would be too high risk to our business, and we wouldn't have the backing of our staff. But there will be, and I know that there are homes out there that are doing that. And certainly I've seen some of the new build care homes that have just opened dedicating whole floors to the hospital, knowing that they're going to bring in the COVID cases, because they've got an opportunity here as well, that they can fill their home very, very quickly. Whereas we know with the new build, they're looking for 3 or 4 residents per month. And they've got an opportunity at the moment where they can fill up 50% of their home overnight. They'll probably have these contracts, and the hope is that when they come out of it, they will retain a proportion of these residents. They're not being regulated as heavily as, well, they're not being regulated at all, quite frankly. So there is opportunity here for people that are willing to take higher risks to make some money and come out of it very nicely. But it's, as a provider that's already operating, we wouldn't be prepared to take those sort of risks. But there are people out there that would and will.
I think also what we're worried about is if the sector doesn't help in some ways with the hospitals, with the discharges, we could be in a position in a couple of weeks' time where the government mandates by law. What they've asked now for all operators to do is we all have to put our capacity on a central register. So the government now knows the full capacity of the aged care sector. It knows all the vacancies, and it knows your staffing situation. The government will then look at that, and it could be that when we hit the surge, the government turns around and says, you have no choice. You are now taking these people because the hospitals are being overrun. And we say, sorry, we don't want to take them. Sorry, this is now the law. You're taking COVID-19. And that's the bit that we worry as an operator, that if we get the point in a couple of weeks' time when the NHS is overrun and it can't cope, is how are we going to cope with the situation where they phone us up and saying, you are taking 15 people who've got COVID on palliative care and they're coming in 2 hours. You have no choice. That's the bit we worry about.
It's just crazy hearing what you're going through. We do have to wrap up though. We'd love to keep talking, but I'm sure hopefully Tom, Brett, if you're open to any other questions that anyone on the line has later on, feel free to flip them through to myself and Cam, and we'll send them through to Tom and Brett. But yeah, thank you very much for the time. It's really, really valuable.
Thank you so much.
It would be fantastic, guys, if we could maybe do it again in a couple of weeks and see how you're coping as you hit peak infection. I think this has already been invaluable, but what you do when the rubber really, really hits the road is going to be so critical for us.
Yeah.
No problem.
Yep.
If you're able.
Thank you very much. Thanks, Cam and Amber. Thanks, everybody.
Thank you very much.
Thanks for organising it.
Thanks,
Stay
guys.
well, everyone. Bye.
Cheers, Tom, Brett. I'll give you a call.
Bye.